A patient's cardiac monitor suddenly begins to blare. Blood pressure drops, heart rate spikes, the waveforms turn red. On a medical surgical unit, a patient clutching their abdomen often presents with symptoms that appear localized, even as an underlying crisis begins to destabilize their entire system. These emergencies involve massive internal hemorrhage, septic shock from a perforated organ, or systemic collapse from pancreatic autodigestion. To manage these high-acuity cases, nurses utilize a structured framework, a systems-based analysis of perfusion and inflammatory markers, designed to catch physiological collapse before it enters an irreversible stage. This approach requires evaluating the patient based on physiological stability rather than their level of discomfort. A stable patient with severe cramping can wait. An unstable patient with dropping perfusion cannot. The first diagnostic track focuses on hemorrhage. Looking at this diagram of the upper gastrointestinal tract, bleeding typically originates from ulcers in the duodenum, stomach, or esophagus. These lesions are frequently driven by heavy NSAID use, H. pylori infection, or advanced liver disease. This endoscopic view shows the source of the threat, a white crater of inflamed tissue where the mucosal lining has eroded, exposing the underlying blood vessels. The appearance of the blood indicates the rate of the leak. Vomit resembling coffee grounds suggests older, partially digested blood from a slower bleed, while bright red emesis with visible clots signals an active, heavy hemorrhage. As the bleeding accelerates, the clinical markers of hypovolemic shock appear: tachycardia, dropping blood pressure, plummeting hemoglobin levels, and cool, clammy skin. The priority is volume restoration. This involves securing 2 large-bore IVs, initiating aggressive fluid resuscitation, and preparing for a blood transfusion. Simultaneously, the bleeding source must be chemically stabilized. Nurses administer proton pump inhibitors like Pantoprazole to neutralize the acid eroding the tissue, or octreotide to reduce pressure in the portal vein in cases of esophageal varices. Because upper GI bleeding equals rapid perfusion loss, the clinical goal is to replace lost volume while mechanically or chemically stopping the leak. The second track focuses on obstruction and infection, specifically within the biliary system. This schematic of the biliary tree shows how Cholelithiasis begins. A yellow cholesterol gallstone forms and lodges within the cystic duct. When the gallbladder contracts to digest a fatty meal, it pushes against this solid blockage, causing sharp, predictable pain. If the stone remains trapped, the stagnant bile triggers cholecystitis. The gallbladder dilates and becomes a site of severe inflammation and bacterial growth. We confirm this inflammation through Murphy's sign. If the patient abruptly stops their inhalation due to pain when you press firmly on their right upper quadrant, the gallbladder is significantly inflamed. Left untreated, the rising pressure within the gallbladder compromises its blood supply. This leads to gangrene, gallbladder perforation, and systemic sepsis. Medical management requires strict NPO status, administering IV fluids and antibiotics, and preparing for a surgical cholecystectomy. In the biliary system, a simple mechanical blockage will escalate into an organ-destroying infection without rapid intervention. Our third track centers on acute pancreatitis and the process of autodigestion.
Normally, digestive enzymes remain inactive until they reach the gut, but triggered by alcohol use or gallstones, these enzymes can activate prematurely, aggressively attacking and digesting the healthy tissue of the pancreas itself. This internal destruction causes severe, sudden epigastric pain that radiates directly through to the patient's back. To verify the cellular damage, we check blood labs. While amylase will be high, an elevated lipase level is the most specific marker of pancreatic destruction. The immediate life threats are systemic. Intense inflammation causes massive fluid shifts into the abdominal cavity, leading to shock. Patients also experience respiratory distress and sudden drops in calcium, which can be identified through muscle tetany or a positive Chvostek sign. Management requires stopping all enzyme production by keeping the patient strictly NPO. We then use aggressive IV fluids to stabilize their circulating volume. By resting the bowel, you remove the fuel for the autodigestion process, while fluid replacement prevents the patient from entering circulatory collapse. When the digestive system fails completely, we turn to our fourth track, external support interventions. Enteral nutrition uses a still-functioning GI tract to provide calories. Tubes can be routed into the stomach or jejunum, as seen here. Because this bypasses normal swallowing, enteral feeding requires constant monitoring for aspiration pneumonia. When the bowel requires total rest, we use total parenteral nutrition, or TPN. This IV bag contains a hypertonic, lipid-rich solution that must be administered strictly through a central line. The high glucose concentration in TPN makes it a massive vector for systemic infection, requiring meticulous line care and continuous blood sugar monitoring. For patients with ascites, a paracentesis is used to drain excess fluid from the abdomen. Because this fluid is rich in protein, draining it too quickly can pull volume from the bloodstream, causing sudden hypovolemia. Finally, patients who have had sections of the bowel removed may require an ostomy. A healthy stoma, like the one in this photo, must appear bright pink or red. A stoma that is pale or purple indicates a loss of blood supply and is a medical emergency. While these artificial support systems sustain the patient, they introduce new avenues for systemic infection and fluid instability. In a clinical triage scenario, you must look at your 4 most unstable patients and decide who requires immediate intervention. Airway, circulation, and signs of shock always take precedence over localized symptoms or pain. The patient with a GI bleed, dropping blood pressure, and falling hemoglobin is your highest priority. They are actively losing perfusion and require immediate volume replacement. Your immediate runner-up is the patient with a rigid abdomen and high fever. These signs point to a perforation and impending sepsis, which require immediate surgical consultation. Patients with severe back pain from pancreatitis or gallbladder pain after eating are in significant distress, but their circulatory systems remain intact. They are secondary to patients in active shock. Clinical mastery in the GI unit relies on the nurse's ability to look past subjective discomfort to protect the patient's perfusion, manage fluid volume, and halt the progression of infection.